Everyone, today's video is going to be about small bowel obstructions. And these are really kind of bread and butter general surgery, and really any type of surgery that involves the abdominal cavity, you're going to have to deal with patients with small bowel obstruction. So really important topic. And that's for multiple reasons. First of all, it's so common. And then second of all, they can actually be quite severe. And to think about why, if we picture this as a piece of small bowel, and let's say it gets blocked off by some sort of scar or adhesion down here, you can imagine what's going to be the pathologic consequences, right? You get a backup of all this fluid. And first of all, that causes some discomfort, distension, usually some nausea and vomiting for the patient, which isn't pleasant. But you can also imagine that this is going to increase pressure in here, pushing out against the walls of this bowel. So the bowel itself is going to stretch and get distended. And of course, if it stretches too much, you can actually get a perforation, and then you have intestinal contents leaking into the abdomen, a quite severe septic or SIRS response, and then also likely some organisms in there as well, causing a really severe intra-abdominal infection. Secondly, if this scar tissue blocks off, let's say, some of this blood supply going to the bowel, then that part of the bowel is going to necrose, will also perforate. So you can see that there's a couple ways to get severely ill with a small bowel obstruction. And that's why we have this historical maxim called never let the sun rise or set on a bowel obstruction. And by that, they meant that if somebody came in with a bowel obstruction overnight, they probably needed emergency surgery before the morning if they weren't getting better already. This isn't so much true anymore, because if you can imagine, you get this vicious cycle of small bowel obstruction, and then to treat it, you do surgery. But as we'll talk about in a little bit, one of the most common causes of a small bowel obstruction is adhesions from surgeries, right? So then you predispose yourself to more small bowel obstructions that you then fix with surgery, right? And then you get in this vicious cycle. So ideally, we like to not operate on people if we don't have to. But of course, there are plenty of situations where these lead to surgical emergencies. And so understanding those situations and being able to treat them is very important. So first, a little bit of background. I like mnemonics. It makes things easy. The most common causes, at least in the US, for a small bowel obstructions are adhesions, bulges, or hernias, and then cancer. So adhesions, these are just essentially, think of them as scar tissue of the abdomen. Anytime you have a surgery, part of that healing process, you're going to develop some scar, and some of these bands of scar kind of adhere things together. That's why they're called adhesions. And they can kind of trap or catch loops of small bowel and cause obstructions. Hernias, I think, is pretty self-explanatory. If a loop of bowel goes into a hernia and gets kind of obstructed or caught at that small neck of the hernia. And then a cancer, of course, can just cause obstruction primarily due to mass effect from that mass. And so adhesions are the most common, at least in the US. I think internationally, bulges or hernias might be more common, and usually cancer is the third. And so these have a pretty classic presentation. The kind of buzzword I want you to think about is this colicky abdominal pain. And what does colicky mean? So colicky essentially means intermittent and crampy. So if we think about that pathology of the small bowel obstruction again, remember back to our abdominal pain video that the small bowel can only really feel chemical irritation and stretch. So this colicky abdominal pain, your small intestine is swollen, and then you get a peristaltic wave progressing in this direction, and it's going to be squeezing against this incompressible fluid, and your body's going to feel that as distension. So there's going to be that crampy pain while that peristaltic wave is happening. Then when the peristalsis stops, that pressure goes away and the pain goes away. So that's why it's a colicky or intermittent crampy abdominal pain. Of course, once again, we've got an obstruction, so things are getting pushed back up. So nausea and vomiting is very common. Actually, it's kind of the body's way of dealing with this pathology. Not passing gas is kind of a classic sign as well, or a symptom. If you're not passing gas, that means that not even air is able to get through this obstruction. In kind of old school parlance, we might have called that complete as opposed to an incomplete bowel obstruction. We don't use that language too much anymore, but that still is an important symptom to ask about. Of course, constipation. Then the key history you want to make sure you don't forget is to ask about past surgeries. Because if we go back to our ABCs, we think about what treatment can we do with these patients? Adhesions, and we're going to talk about this in a second, can usually be managed non-operatively. Bulges or hernias usually get an operation, and cancer, you definitely need to go in and take out that obstructing cancer. But remember that adhesions are almost only caused by surgery. So if a patient has no surgeries, but they're having a small bowel obstruction, you don't notice any hernias on exam, then you've really got to be worried about some sort of missed malignancy. Now, this is less common nowadays with better imaging, but historically, somebody with a small bowel obstruction and what's called a virgin abdomen, or an abdomen that had never had any operation, was essentially mandating surgery as well. So that's a component of the history that you want to make sure you don't miss. And then looking at our more objective data on physical exam, patients will usually be uncomfortable. They'll have a big distended abdomen, usually mild diffuse tenderness, if anything. Remember that frequently they'll only have that pain intermittently, that colicky abdominal pain. If they're having constant pain or really severe pain, then you want to think about perforation and peritonitis. And of course, check for hernias. It's really easy to forget to check the groin for hernias in a patient like this. And then imaging, if you get a chest x-ray, or sorry, should say an abdominal x-ray. If you get an x-ray, you might see air fluid levels, which you can Google an image of that, see what it looks like. But most commonly, these patients are getting a CT scan. You can get quite a bit of data from that, usually with PO contrast. Then, like I said, the key is to kind of rule out the surgical emergency. So if a patient is extremely sick, there's no role for non-operative management, and you're really going to have to be thinking about the OR right away. So really severe vital sign abnormalities, not everyone, most people will be a little bit tachycardic and maybe a little bit hypotensive because of fluid shifts and dehydration, but especially if you give them some fluid, they're still very ill. That's concerning. Severe lab abnormalities, you want to be thinking about checking your lactate. Really high white blood count can be concerning as well. And of course, like always, anytime somebody has diffuse peritonitis, that really concerning abdominal exam, we talked about that in our abdominal pain video as well, if you need to review. But if they have that or any sort of free air on imaging, that's a sign that their bowel has perforated, and you're going to have to go in and take out the perforated segment. And then there's something called a closed loop bowel obstruction. So I wanted to go over that a little bit. So if we have our piece of bowel, typically I've been drawing it out where one end is blocked off, but a closed loop is just like it says in the name, the loop is closed. There's actually obstruction at two ends. And so you can imagine you lose that pop-off valve for fluids to come up and cause nausea and vomiting, right? So all they're going to do as the bowel continues to get inflamed and leak fluid is push out against the sides of this bowel, and it's going to dilate until it perforates. And there's no way for us to temporize it with something like an NG tube or the patient vomiting. And so that is a much more concerning presentation that's not going to get fixed without surgery. The other way you can have a closed loop is what's called volvulus, where you essentially have a loop of bowel and then it spins around itself at the neck here. So you end up with kind of this pretzel looking twist of bowel. And so of course there you have obstruction here, which is closed looped. But you also got to remember that all these blood vessels going to this bowel at the bottom of the loop have been obstructed as well. So that is going to cut off blood supply to this bowel. It's going to necrose and perforate. Your patient's going to get extremely sick. So anytime somebody has a closed loop obstruction on imaging, they're going to get an emergency surgery. Then finally, any signs of threatened bowel on the CT scan. In these, it's better to just look at CT images to see what some of these signs are. But we're talking about pneumatosis, which is like air in the bowel wall. The more severe presentation of that is what's called portal venous gas, PVG, where the gas has actually traveled up the portal vein, and you're seeing that in the liver. If you're seeing hypoenhancement of the bowel, there's no contrast getting to it. That's a concern for poor blood flow. There could be things like mesenteric haziness, etc. But that really just comes with a lot of time and experience reading CT scans. And of course, finally, if somebody has that virgin abdomen or they've never had surgery and they're having a small bowel obstruction, many people will still have a lower threshold to go in there, but that's not necessarily a surgical emergency. All right, so if somebody is not having a surgical emergency, then what do you do? And so this is kind of very regimented, same thing every time. So obviously NPO, bowel rest, you don't want to put anything else in that closed system. You want to place an NG tube, which is going to decompress everything. Remember, the vast majority of these are caused by adhesions, and We get this back up, you get this fluid extending that small bowel. And so if we put an NG tube in the stomach, if you want to review your types of tubes, we have a video on that as well. The NG tube just really helps to suck out all this fluid, decompress this area of the small bowel. A lot of times that can be enough to decrease the lumen and actually allow the bowel to slip back out from outside of that obstruction. So even doing nothing else but decompressing people can potentially treat a small bowel obstruction. Of course, everybody needs some IV fluid. So if you imagine you put an NG tube in and 2 or 3 liters of fluids comes out, those are 2 to 3 liters of fluid that patient would typically be absorbing. They've usually also been throwing up before they've come in. And so all the fluid that they're drinking, all the fluid that their body is producing above the level of that obstruction, that's just not being absorbed. And so usually people need a couple liters of fluid boluses, and you certainly want to be giving them maintenance fluids because they will be dehydrated when they come in with a small bowel obstruction. And then, of course, you're always worried that even with the best imaging, even with the best physical exam, that you might have missed something. So you want to really keep a close eye on these patients, do abdominal exams serially, and just make sure they're not developing any worsening pain or, of course, some sort of peritonitis that would cause you to need to go to the OR. So a brief note on NG tubes. I said that we did have that other video. But I did just want to talk briefly here. This is probably the most common situation we place NG tubes in. So if you have somebody, say this is a giant nose here, when you're placing an NG tube, first of all, these are usually like 14 to 18 French. If you're struggling with it, you actually want a bigger tube as opposed to a smaller, because the problem is typically not a small area of the lumen that you're passing it through, but it's actually it getting coiled, and a bigger tube is stiffer and coils less. But when you're putting this up somebody's nose, do not point it straight up like your finger goes in when you're picking your nose or something. If you do that, you're going to put this tube, it's going to drive straight up into the top of the nasal sinuses, and it's going to be really uncomfortable. So what you actually want to do is essentially get it in the nose, and then you want to angle it straight back, pointing towards the back of the head. That's going to facilitate it passing through the nasal passages, kind of bumping into the back of the upper throat, the back of the nose, and just curving down nicely into the esophagus. And you'll usually do that and have them drink a little bit of water while it's going in, and the tube placement can actually go quite smoothly. You'll get that really crucial decompression that you need for this illness. And this is kind of bonus knowledge for a medical student. I wouldn't necessarily expect them to know it, but this can, excuse me, give your team something to do while you're just waiting for them to decompress non-operatively. And actually it's been shown to be quite helpful in terms of decreasing the times that people need operations or small bowel resections for small bowel obstructions. And that's what's called this Gastrographin challenge. Gastrographin is a hyperosmolar contrast agent. And so typically what you would do is you'd place the NG tube just like you normally would. You take a couple hours to suck a bunch of fluid out. Then you would administer this contrast agent through that NG tube. And then you'd get an x-ray at usually maybe 4 or 8 and 24 hours and see if contrast has made it through the small bowel all the way to the colon. And so the Gastrographin does 2 things. One, it's diagnostic, kind of like I just described. If you see contrast in the colon at 8 or 24 hours, you're pretty sure that the small bowel isn't obstructed anymore. But also the hyperosmolar nature of the Gastrographin also helps. So if you're picturing, once again, we have our obstruction here, and the bowel here is going to be really angry, right? Like it's going to be edematous and inflamed. And you can imagine this thick, angry, and of course dilated bowel is not very likely to be able to slip out from this band of scar tissue. And so the NG tube helps with the decompression. Then the Gastrographin comes in here, and it's hyperosmolar. So it's actually going to draw some of this fluid from the angry, edematous small bowel into the lumen and further work to decrease the pressure, decrease the forces kind of holding this bowel in place under this obstruction. So that's why we say it can be diagnostic and therapeutic. And at least at our institution, we use it quite frequently for these small bowel obstructions. And the other thing it can do is if you're just decompressing someone, they're just sitting there, they're not really getting better, you're not really getting worse, you're not sure what to do. But if you've done the Gastrographin challenge and at 24 hours, you don't have any contrast in the colon, you think it's highly likely that this patient's going to need the operating room. So you can get that moving maybe a little bit earlier and not have them just sitting there for days and days with an NG tube, maybe requiring TPN, et cetera. So it can be helpful in that way as well. But like I said, that's just a little bit of bonus material. Really think about small bowel obstructions, think about your ABCs, most common causes, adhesions, bulges or hernias, and cancer. Make sure you're not dealing with the surgical emergency, and then have a good grasp on your non-op management, which the key is NG tube decompression. Make sure they're resuscitated with IV fluids. And then for a bonus, you can think about Gastrographin challenge. These videos are not intended for clinical use. They're for educational purposes only. Do not use them to diagnose or treat any diseases, and we will see you next time.